What are the primary differences between breastfeeding and formula feeding in infants, and how should a pediatric nurse assess and support parents in choosing the right feeding method for their infant? Answer: breastfeeding and formula feeding are both essential methods of providing nutrition to infants, but they differ in several key ways. Breastfeeding provides natural immunity, enzymes, and antibodies that support an infant's immune system and promote healthy development. It also adapts to the baby's needs over time. Formula feeding provides a convenient and consistent source of nutrition but lacks the immunological benefits of breast milk. Formula can be an option for mothers who cannot breastfeed, whether due to medical conditions, work constraints, or personal preference. Pediatric nurses should assess the infant's nutritional needs, growth patterns, and any maternal concerns or challenges in breastfeeding, including issues such as latch milk supply and nipple pain. Nurses should also educate parents on the pros and cons of each option, considering the infant's health, family dynamics, and any medical conditions, e.g., galactosemia or metabolic disorders, that may impact feeding choices. Describe how a pediatric nurse should manage a child who is a picky eater and has food aversions. What are the key interventions to encourage healthy eating habits? Answer: management of picky eaters and food aversions in children requires a holistic approach that focuses on behavioral and nutritional support. Establishing a routine, offer meals and snacks at regular intervals to ensure the child receives appropriate nutrients even if the quantity is small. Modeling behavior, encouraging parents and caregivers to model healthy eating habits can help improve a child's acceptance of new foods. Positive reinforcement, praise and reward the child for trying new foods without pressuring them. Avoiding force feeding. Force feeding can increase negative associations with eating. Gradual introduction of new foods. Slowly introduce new foods alongside familiar favorites, incorporating fun and variety. Presenting food in an attractive and creative way, making food look like animals, can make meals more appealing. Key considerations: if the picky eating leads to nutritional deficiencies such as iron deficiency, anemia, the nurse should collaborate with a dietitian to plan balanced meals and consider supplementation as needed. A 3-year-old child presents with failure to thrive and a suspected iron deficiency. What are the steps a pediatric nurse should take in assessing and managing this condition? Answer: failure to thrive (FTT) in children is a condition where a child's growth rate falls below the 5th percentile for weight or height. The pediatric nurse should follow a structured approach: assessment, review of medical history, assess for underlying causes such as poor feeding, chronic illness, or neglect. Dietary assessment, evaluate the child's nutritional intake, focusing on the intake of iron-rich foods, e.g., red meat, leafy greens, fortified cereals. Physical exam, look for signs of malnutrition such as pallor, irritability, or delayed developmental milestones. Diagnosis, blood tests, obtain a complete blood count, CBC, serum ferritin, and serum iron levels to confirm iron deficiency, anemia. Growth charts, plot the child's weight and height to assess patterns and growth velocity. Management, iron supplementation, prescribe oral iron supplements, e.g., ferrous sulfate, and educate the family on how to administer it. Dietary recommendations, encourage a diet rich in iron and vitamin C, which enhances iron absorption. Follow-up, monitor the child's growth progress and iron levels with follow-up appointments. Relevant guidelines, the American Academy of Pediatrics recommends iron supplementation for infants at risk of deficiency, especially those not receiving iron-fortified formula or breast milk after 6 months of age. It is crucial to manage iron deficiency promptly to avoid developmental delays and other complications. Mr. Johnson, a father of a 5-month-old infant, has been exclusively breastfeeding but is now concerned that his infant is not gaining enough weight. After consulting with his pediatric nurse, what should Mr. Johnson do to address his concerns and ensure his child is receiving adequate nutrition? Answer: Mr. Johnson's concerns about his infant's weight gain are valid, as this can be a sign of undernutrition or breastfeeding difficulties. The pediatric nurse should advise him on the following steps: assess breastfeeding techniques, ensure the infant is latching properly and effectively extracting milk. The nurse may suggest a lactation consultant if issues such as poor latch or insufficient milk supply are identified. Monitor infant's weight. Regular weight checks are necessary to track the infant's growth. Rule out medical issues. If the infant's weight continues to be insufficient, consider assessing for medical causes such as reflux or a tongue tie. Supplementation if necessary. If breastfeeding alone is insufficient, recommend supplementing with formula or expressed breast milk after feed under guidance from the healthcare provider. Encourage frequent feeds. Infants may need to nurse more frequently to meet their growth needs, especially during growth spurts. What are the key differences between enteral and parenteral nutrition, and when should each be used in pediatric patients? Answer: enteral and parenteral nutrition are two methods of providing nutritional support when a child cannot consume adequate nutrition orally. Enteral nutrition involves the delivery of nutrients directly to the gastrointestinal tract, typically via a feeding tube, nasogastric tube gastrostomy. This method is preferred if the gastrointestinal system is functional, as it helps maintain gut integrity, reduces the risk of infection, and promotes nutrient absorption. Parenteral nutrition is the intravenous delivery of nutrients bypassing the digestive system. It is used when the gastrointestinal tract is non-functional or cannot be accessed, such as in cases of bowel obstruction, severe malabsorption syndromes, or after certain surgeries. Indications: enteral nutrition should be the first choice when possible, as it supports normal gastrointestinal function. Parenteral nutrition is typically used in cases of short bowel syndrome, severe intestinal failure, or when enteral feeding is not feasible for an extended period. What are the main complications associated with central venous catheters, CVC, and peripherally inserted central catheters, PIC, and how can pediatric nurses minimize these risks? Answer: central venous catheters, EVCS, and peripherally inserted central catheters, PICC lines, are essential for long-term intravenous access in pediatric patients, but they carry certain risks. Infection: catheters provide a direct pathway for bacteria into the bloodstream, leading to catheter-associated bloodstream infections. CLABSI: prevention: strict aseptic technique during insertion and maintenance, frequent dressing changes, and regular flushing to prevent occlusion are key practices to minimize infection risks. Thrombosis: the presence of the catheter increases the risk of thrombosis at the insertion site. Prevention: nurses should monitor for signs of swelling or discomfort at the insertion site and ensure proper positioning and fixation of the catheter. Occlusion: the catheter may become blocked by blood, clots, or medication buildup. Prevention: ensure that the catheter is flushed regularly with saline and heparin as per institutional protocols. What are the essential steps a pediatric nurse should follow when preparing a child for a lumbar puncture? Answer: preparing a child for a lumbar puncture involves both emotional and physical preparation to reduce anxiety and ensure the procedure is done safely. Pre-procedure preparation: explain the procedure to both the child in an age-appropriate way and the parents, addressing concerns and explaining the steps. Obtain informed consent from the parent or guardian. Ensure the child is in a comfortable position, typically in a lateral decubitus position, curled up to open the intervertebral spaces. Sedation and pain management: ensure local anesthesia is applied to the puncture site to minimize discomfort. Depending on the child's age and cooperation, light sedation may be considered. Post-procedure care: monitor the child for complications such as headaches, infection, or bleeding. Keep the child in a supine position for a specified period to minimize the risk of post-LP headaches. How should a pediatric nurse respond to alarm fatigue in the pediatric ICU, where multiple monitors are used to track a patient's vital signs? Answer: alarm fatigue occurs when healthcare providers become desensitized to frequent alarms, potentially leading to missed critical warnings. Proper alarm management: nurses should assess the patient's condition and filter unnecessary alarms. This includes setting appropriate alarm thresholds based on the patient's baseline values and clinical condition. Education and training: continuous education on alarm management should be provided to all staff, focusing on the importance of responding promptly to critical alarms and reviewing alarm settings regularly. Alarm reduction strategies: use smart alarms that differentiate between true emergencies and non-critical notifications. Prioritization: nurses should be trained to prioritize alarms based on severity, enabling a more effective response during high-stress situations. Relevant guidelines: the Institute for Safe Medication Practices and FDA guidelines emphasize alarm management and safety protocols in healthcare settings to reduce alarm fatigue. What is the role of pulse oximetry in pediatric nursing, and how can nurses ensure its effective use in monitoring oxygen saturation levels? Answer: pulse oximetry is a non-invasive method of monitoring the oxygen saturation of hemoglobin, essential for assessing respiratory function in pediatric patients. Nurses must place the sensor correctly, ensure the sensor is applied to a well-perfused area, such as the finger or toe, to obtain accurate readings. Monitor trends: observe not only the oxygen saturation (SPO), but also changes over time. A single reading may not provide a full picture of the patient's respiratory status. Consider other factors. Environmental factors like bright light, nail polish, or patient movement may interfere with readings. Respond to low readings when oxygen saturation falls below the normal range, typically 95–100%. For healthy children, immediate intervention is necessary, which may include administering supplemental oxygen or assessing for respiratory distress. Relevant guidelines. The American Thoracic Society provides guidelines on the use of pulse oximetry, including recommended ranges and clinical responses to normal readings. How should a pediatric nurse manage a child with severe allergic reactions to food, and what emergency steps should be taken? Answer: in cases of severe food allergies, the nurse should follow these steps. Identify symptoms. Severe allergic reactions may include difficulty breathing, swelling of the face or throat, wheezing, or hives. Administer epinephrine. If anaphylaxis is suspected, administer epinephrine immediately via an auto-injector, e.g. EpiPen, as this is the first-line treatment for anaphylaxis. Call for help. Notify the healthcare provider and activate the emergency response system if needed. Monitor vitals. Continuously monitor the child's vital signs, including heart rate and oxygen saturation. Follow-up care. The child should be observed in a medical facility for several hours after the reaction, as biphasic anaphylaxis can occur. Relevant guidelines. The American Academy of Pediatrics provides protocols for the emergency management of anaphylaxis in children, emphasizing the use of epinephrine as the first-line treatment. What strategies can a pediatric nurse recommend to parents dealing with a toddler who frequently throws temper tantrums when their independence is challenged? Answer: for toddlers exhibiting temper tantrums due to struggles with independence, the pediatric nurse can suggest the following strategies. Provide consistent routines. A predictable routine helps toddlers feel secure, which can reduce frustration. Offer choices. Giving toddlers some control, such as letting them choose between two options, helps them feel empowered without overwhelming them. Validate emotions. Acknowledge the child's feelings of frustration or anger. This validation can help them regulate emotions. Set clear, age-appropriate boundaries. Firm yet loving discipline with clear expectations provides structure. Use distraction. Redirecting the child's attention to another activity can help prevent the escalation of tantrums. Nurses should educate parents on child development and strategies for fostering emotional regulation, as per Erikson's psychosocial development theory, which emphasizes autonomy during the toddler years. A pediatric nurse is assessing a 9-year-old child who seems withdrawn, avoids social interaction, and exhibits a lack of confidence in their schoolwork despite performing well. Which theory would help explain this child's behavior, and what interventions would you suggest? Answer: this child's behavior could be explained through Erikson's theory of psychosocial development, particularly during the industry versus inferiority stage, which occurs between the ages of 6 and 12. During this stage, children develop a sense of pride in their accomplishments and abilities. A lack of confidence despite academic success could indicate feelings of inferiority or low self-esteem. Interventions include encouraging the child's efforts and providing positive reinforcement, involving them in group activities that align with their interests to build social skills. Educating parents on the importance of recognizing their child's strengths, which can help counter feelings of inferiority. Fostering a positive self-concept through supportive interactions is key to developing a healthy identity. What are the key factors that contribute to increased risk-taking behaviors in adolescence, and how can a pediatric nurse intervene to mitigate these behaviors? Answer: adolescence is marked by significant hormonal changes, brain development, and peer influence, which can contribute to an increased propensity for risk-taking behaviors. Jean Piaget's theory of cognitive development suggests that adolescents are in the formal operational stage, which allows for abstract thinking but may lead to an overestimation of invulnerability. Peer pressure and the desire for independence also play significant roles. Interventions include educating adolescents on the potential consequences of risky behaviors such as substance abuse or unsafe driving, encouraging open communication and providing a supportive environment, promoting healthy coping mechanisms such as sports, hobbies, or engaging in community activities to fulfill the need for autonomy and peer acceptance in positive ways. Fostering a relationship based on trust and providing guidance can help mitigate impulsive decision-making. Mrs. Johnson is concerned about her 3-year-old child's safety while playing outdoors. Her child enjoys climbing trees and playing near a pond. What safety measures should Mrs. Johnson take to prevent potential accidents, and what resources can the pediatric nurse provide to educate her on safety? Answer: Mrs. Johnson should take several safety measures to minimize the risk of injury. Supervision. Always supervise outdoor activities, especially around potential hazards like trees and ponds. Child-proofing the environment. Ensure that the pond is fenced off and that trees are safe to climb or limit access to dangerous areas. Proper gear. Ensure her child is wearing appropriate clothing and footwear for outdoor activities. Teach safety skills. Educate her child about not climbing high trees or venturing near the water without an adult. The pediatric nurse can recommend resources such as safe play guidelines from the American Academy of Pediatrics (OP), which provide detailed safety education for parents, and community programs that focus on injury prevention. The nurse can also provide information on car seat safety and home injury prevention as part of a comprehensive safety plan. During adolescence, identity development is critical. How does Erikson's theory explain the role of peer pressure in adolescent behavior, and what strategies can pediatric nurses use to support healthy identity formation? Answer: Erikson's theory places adolescents in the identity versus role confusion stage, where they seek to establish their own identity, and peer influence plays a significant role. Peer pressure can either encourage conformity or prompt adolescents to experiment with different roles, which can either facilitate identity formation or lead to confusion. Nurses can intervene by encouraging self-reflection through open-ended discussions about the adolescent's values, beliefs, and aspirations. Promoting peer support groups where adolescents can explore identity in a safe, non-judgmental space, offering resources for mental health support to address the challenges associated with peer pressure and identity confusion. Helping adolescents develop a strong sense of self through guidance and support can prevent issues related to role confusion. What strategies should a pediatric nurse implement when working with a family that is managing a child's diabetes? Answer: managing diabetes in children requires a comprehensive approach to nutrition, medication, and lifestyle. The pediatric nurse can implement the following strategies: education on carbohydrate counting, teach families how to count carbohydrates and balance insulin administration accordingly, meal planning and portion control, help families create a balanced meal plan that aligns with the child's nutritional needs and insulin regimen, monitoring blood glucose levels, educate families on how to regularly monitor blood glucose levels and recognize signs of hypo or hypoglycemia, incorporate physical activity, encourage age-appropriate physical activities that support the child's overall health and assist in glucose management. The nurse should also provide emotional support to the family, as managing diabetes can be stressful and overwhelming, and ensure that resources for ongoing diabetes management, such as local support groups, are available. Why is it important for pediatric nurses to stay up to date on immunization schedules and catch-up plans for children, and what might be the consequences of delaying vaccinations? Answer: pediatric nurses must stay informed about immunization schedules to ensure children receive the appropriate vaccines at the right time. Delayed vaccinations can increase the risk of vaccine-preventable diseases and disrupt herd immunity, especially in communities with low vaccination rates. The CDC's immunization schedule provides clear guidelines for childhood vaccinations, and the nurse should be familiar with catch-up schedules for children who have missed vaccines. Delayed vaccinations can result in outbreaks of diseases like measles, mumps, and whooping cough, which can lead to significant morbidity and mortality. Pediatric nurses should educate parents on the importance of timely vaccinations and offer guidance on maintaining an up-to-date vaccination schedule, referring to authoritative sources like the CDC and AAP. At what stage of development do children typically begin to master emotional regulation, and how can pediatric nurses support this development? Answer: children generally begin mastering emotional regulation in the preschool years, 3-5 years, as part of Erikson's initiative versus guilt stage. During this period, they begin to understand and express their emotions in more socially acceptable ways. Pediatric nurses can support emotional regulation by encouraging parents to model calm and controlled emotional responses, teaching children simple coping mechanisms such as deep breathing or counting when upset, promoting imaginative play to help children work through complex emotions. By fostering a supportive environment, nurses can help children navigate their emotions in healthy ways. What are the key recommendations for pediatric nurses regarding oral health education, particularly for preventing early childhood cavities? Answer: the pediatric nurse should provide education on the following oral health practices. Early introduction to oral hygiene. Parents should begin cleaning an infant's gums with a soft cloth before teeth appear. Once teeth erupt, they should begin brushing with a small, soft toothbrush and fluoride toothpaste, limiting sugary foods and drinks. Sugary snacks and beverages should be minimized, as they increase the risk of cavities. Regular dental visits. Encourage families to schedule the first dental visit by age 1 and continue regular visits. Fluoride supplementation. If the child lives in an area without fluoridated water, fluoride supplements may be recommended. Parental role modeling. Parents should set a positive example by maintaining their own oral hygiene. The nurse should educate families on the importance of oral health as part of overall pediatric health promotion and provide resources on dental care and local pediatric dental services. 5-year-old patient presents with a fever, cough, runny nose, and conjunctivitis, followed by a rash that begins on the face and spreads downward. The patient's vaccination history is unknown. Given the clinical presentation, what are the most likely conditions and what is the recommended action in terms of diagnosis and management? Answer: the symptoms describe fever, cough, runny nose, conjunctivitis, and a characteristic descending rash are consistent with measles. Measles is a highly contagious viral infection that can cause severe complications such as pneumonia, encephalitis, and death, especially in unvaccinated children. The MMR, measles, mumps, rubella vaccine is highly effective at preventing measles, and children are typically vaccinated at 1–15 months with a booster at 4–6 years of age. Recommended action: diagnosis. Diagnosis is confirmed by clinical symptoms and can be supplemented by laboratory tests such as detecting measles antibodies or PCR for the virus. Management. Since the patient is likely unvaccinated, isolation is crucial to prevent spread. Supportive care for fever and discomfort, along with monitoring for potential complications, is the mainstay of treatment. Guideline: the CDC recommends all children receive 2 doses of the MMR vaccine, ideally at ages 1–15 months and again at 4–6 years to prevent outbreaks. A 7-year-old patient recently diagnosed with acute lymphoblastic leukemia or is undergoing chemotherapy. The child's blood counts are dropping, and the family is concerned about potential side effects. What are the most common side effects of chemotherapy in pediatric leukemia patients, and how should these be managed? Answer: chemotherapy for acute lymphoblastic leukemia or commonly leads to several side effects, primarily due to the suppression of bone marrow, which affects the production of blood cells. These side effects include myelosuppression, low blood cell counts leading to anemia, neutropenia, increased infection risk, and thrombocytopenia, increased bleeding risk, nausea and vomiting, often treated with antiemetic medications. Mucositis, inflammation of mucous membranes leading to painful sores, can be managed with mouth care. Local anesthetics and pain relief. Hair loss, common with some chemotherapeutic agents but not requiring specific treatment. Fatigue, a common side effect of both the disease and treatment, managed with rest and support management. Infection prevention is critical, including isolation when nootropic. Blood transfusions may be necessary for severe anemia or thrombocytopenia. Supportive care, such as pain management for mucositis, anti-nausea medications, and hydration are essential components of treatment. A 3-year-old patient presents with a high fever, a sore throat, and a red, swollen throat. The child has no cough but has a history of recent exposure to a child with bacterial pharyngitis. How should you differentiate between a viral and bacterial infection, and what is the appropriate management plan? Answer: differentiating between viral and bacterial infections, particularly pharyngitis, can be challenging. The most common cause of bacterial pharyngitis is group Streptococcus gas, whereas viruses such as adenovirus or rhinovirus are also frequent culprits in children. Key features to distinguish between the two include bacterial infection, gas, sudden onset of sore throat, high fever, swollen, tender lymph nodes, absence of cough. Positive rapid antigen test or throat culture confirms the diagnosis. Viral infection, gradual onset of symptoms associated with cough, rhinorrhea, and hoarseness, less likely to have swollen lymph nodes or tonsillar exudates. Management: if bacterial pharyngitis is confirmed, treat with antibiotics, penicillin or amoxicillin for 10 days to prevent complications such as rheumatic fever. If viral, supportive care, rest fluids, pain relievers is appropriate. Guideline: the CDC and American Academy of Pediatrics emphasize avoiding unnecessary antibiotic use for viral infections to prevent resistance and side effects. Rapid antigen testing or throat culture is recommended for definitive diagnosis in suspected cases of bacterial pharyngitis. Emily, a 2-year-old child, presents with a 24-hour history of vomiting and diarrhea. She is lethargic, with a dry mouth, decreased urine output, and sunken eyes. You suspect moderate dehydration. What steps should you take in her management? Answer: based on Emily's presentation, she is showing signs of moderate dehydration, lethargy, dry mouth, decreased urine output, sunken eyes. The primary goal is to rehydrate and restore her fluid and electrolyte balance. Management steps: oral rehydration therapy, or, if Emily is able to tolerate oral intake, start with oral rehydration solutions which contain the right balance of electrolytes and sugars to rehydrate. Offer small amounts frequently. G. 510 ml every 5 minutes. Intravenous fluids. If Emily is unable to tolerate ORS, is showing signs of severe dehydration, e.g. very lethargic, sunken fontanelle in infants, or has severe electrolyte imbalances, IV rehydration with isotonic solutions such as normal saline or Ringer's lactate is necessary. Electrolyte monitoring. Monitor for electrolyte imbalances such as hypokalemia or hyponatremia, especially if diarrhea has been prolonged or if IV fluids are used. Dietary adjustments. Once Emily's condition stabilizes, she should gradually resume normal feeding, breastfeeding or formula for infants, solid foods for toddlers. A 6-month-old infant with spina bifida is referred for further evaluation. The infant has significant motor impairment below the level of the lesion and has developed hydrocephalus. What interventions should be initiated to optimize the child's developmental and functional outcomes? Answer. Spina bifida is a neural tube defect where the spinal cord does not close properly during fetal development. Hydrocephalus, often seen in these children, results from an accumulation of cerebrospinal fluid (CSF) in the brain, requiring surgical intervention, e.g. shunt placement, to prevent brain damage. Interventions. Early surgery. Early closure of the myeloma meningocele, if not already performed at birth, is essential to minimize neurological damage. Hydrocephalus management. Shunt surgery is required to prevent further brain damage due to excessive CSF buildup. Physical therapy. Early intervention with physical therapy to maximize motor function, prevent deformities, and encourage developmental milestones. Urological care. Many children with spina bifida also have neurogenic bladder, requiring regular urological evaluation and management. Multidisciplinary approach. A team including a pediatric neurosurgeon, physical therapist, urologist, and developmental pediatrician is crucial for long-term management. A 12-year-old child with terminal cancer is experiencing severe pain despite being on a morphine regimen. The family is concerned about the potential side effects and the risk of opioid tolerance. What strategies should you use to optimize pain management and address the family's concerns? Answer. In pediatric palliative care, pain management should be holistic, addressing both physical and emotional aspects. If opioid tolerance or inadequate pain control is suspected, the following strategies should be considered. Review pain assessment. Ensure the child's pain is accurately assessed using age-appropriate tools, e.g. FLA-CC scale for nonverbal children. Opioid dose adjustment. Titrate the opioid dose carefully based on the child's pain levels and response, ensuring that the child is comfortable while minimizing side effects like sedation or constipation. Adjuvant medications. Consider adding adjuvants, e.g. NSAIDs for bone pain, antidepressants for neuropathic pain to help manage specific pain syndromes. Non-pharmacological approaches, techniques such as distraction therapy, guided imagery, or music therapy can be effective adjuncts to pain management. Family education. Address the family's concerns about opioid use, explaining the goal is comfort, not prolonging life or hastening death, and emphasizing that in terminal illness, pain management is paramount. A 4-month-old infant presents with a cough that is increasing in severity, associated with periods of apnea, followed by a high-pitched root. The infant is not fully vaccinated. What is the likely diagnosis and what interventions should be initiated? Answer. The symptoms described. Coughing, apnea, and a whooping sound are highly suggestive of pertussis. Whooping cough caused by the bacterium Bordetella pertussis. Pertussis is highly contagious, and infants, especially those who are unvaccinated, are at high risk for severe complications, including apnea and pneumonia. Interventions. Diagnosis. Confirm the diagnosis with a nasopharyngeal culture or PCR test for Bordetella pertussis. Antibiotics. Treat with macrolide antibiotics, e.g. azithromycin, to prevent transmission and reduce the severity of symptoms. Supportive care. Oxygen therapy and respiratory support may be required for infants with severe apnea or pneumonia. Vaccination. After recovery, ensure the infant receives the appropriate DTaP, diphtheria, tetanus, and a cellular pertussis vaccine as part of their routine immunization schedule. A 4-year-old child with Down syndrome has delayed speech development and exhibits some signs of hypothyroidism, including constipation and cold intolerance. What diagnostic tests should be ordered to confirm the suspected condition, and what interventions should be implemented? Answer. Down syndrome increases the risk for several comorbidities, including hypothyroidism. Children with Down syndrome often have congenital hypothyroidism or develop autoimmune thyroid disease over time. Diagnostic tests. Thyroid function tests. Order a TSH, thyroid-stimulating hormone, and free to assess thyroid function. Anti-TO antibodies may also be tested if autoimmune thyroiditis is suspected. Interventions. If hypothyroidism is confirmed, initiate treatment with levothyroxine, adjusting the dose based on follow-up thyroid function tests. Ongoing developmental assessments to monitor speech and motor delays are important to guide early interventions, including speech therapy and occupational therapy. Guideline. The AAP recommends routine screening for thyroid disorders in all children with Down syndrome, typically starting at birth and then periodically as they grow. A 2-year-old child presents with a history of fever, irritability, and tugging at the ear. On examination, there is a red, bulging tympanic membrane with decreased mobility. The child has had recurrent ear infections. What is the most likely diagnosis and what is the recommended treatment? Answer. The symptoms of fever, irritability, and a bulging tympanic membrane are consistent with acute otitis media (ARM), a common infection in young children caused by bacteria such as Streptococcus pneumoniae or Haemophilus influenzae. Treatment. Antibiotics are indicated for children under 6 months of age or for children with severe symptoms. Amoxicillin is typically the first-line therapy. Pain management with analgesics, e.g. acetaminophen, is important for symptom relief. If AOM is recurrent, consider tympanostomy 2 placement to prevent further infections. Guideline. The AAP recommends careful observation in children aged 6 months to 2 years with mild symptoms and without high fever. Antibiotic therapy should be started if symptoms worsen or fail to resolve. A 6-year-old child presents with a vesicular rash that has begun on the trunk and is spreading to the face and limbs. The rash is described as having various stages of development. The child's vaccination status is unclear. What is the likely diagnosis and what are the key considerations for management? Answer. The presentation of a vesicular rash that progresses through stages, macules, papules, vesicles, and scabs is highly suggestive of varicella chickenpox caused by the varicella zoster virus (VB). Management. Diagnosis is typically clinical, but laboratory confirmation can be obtained through PCR or direct fluorescent antibody testing. Supportive care includes antihistamines for itching and acetaminophen for fever relief. Avoid aspirin due to the risk of Ray's syndrome. Vaccination with the varicella vaccine is recommended for prevention, with 2 doses typically administered at 1 to 1.5 months and for 6 years of age. Guideline. The CDC recommends the varicella vaccine for all children, with catch-up vaccination for those who have not received it by age 13. Treatment for varicella in immunocompetent children is usually supportive, but acyclovir may be used in severe cases. What are the key guidelines for the safe handling and administration of vaccines in pediatric patients, and how can a nurse minimize discomfort during the vaccination process? Answer. The safe handling and administration of vaccines in pediatric patients are critical to ensuring their effectiveness and minimizing risks. Key guidelines include storage. Vaccines must be stored at the recommended temperature ranges, typically between 2°C and 8°C, to maintain their potency. Any deviation from the storage guidelines can render the vaccine ineffective. Proper administration. Vaccines should be administered using the appropriate needle size and injection technique. Most vaccines are administered intramuscularly, in the thigh for infants, but some may be given subcutaneously or intradermally. Documentation. Accurate records should be kept for all vaccines administered, including the date, vaccine type, and the site of administration, to minimize discomfort during vaccination. Use topical anesthetics, e.g. MLA cream, to reduce pain at the injection site. Distract the child with toys, music, or videos to help reduce anxiety. Offer comfort measures after the injection, such as cuddling, pacifiers for infants, or a small treat for older children.